Assalamu alaikum, everyone. I am Talah Namour, and I'm going to give you the eye today. We're going to discuss basically the anatomy of the eye and cover the physiology lectures. The physiology lectures are a bit challenging, even for me, صراحة. But inshallah, we're going to go over them together and make it as easy as possible. تمام? So let's start. First of all, our eyes are the organs that we see with, okay, and they are located in these two sockets, or the sockets that are found in our skull. تمام. These sockets are made up of a bunch of bones, as you can guys see. We have like so many different colors, which are basically different bones. And these sockets are placed in a way where they kind of look like a pyramid. You can see that. So basically, we have this is basically where the eyes are, and then we have like a roof, a floor, a medial, and a lateral wall, and they all basically converge into an apex. Tamam. Um, and they are kind of slanted in a way that is, subhanallah, perfect just for our vision. Tamam. So this is basically the different bones that make up our like eye socket. Okay, so we have the frontal, we have the sphenoid, we have the ethmoid, zygomatic, maxillary, palatine, and lacrimal. تمام. So all of these bones come together to give us our orbit. تمام. And these basically are then divided into a superior wall, medial, the floor, and then the lateral. And we can kind of see what makes up each wall. So basically, for the superior wall, the frontal bone and the sphenoid are the two bones that mainly make up the superior wall. And why is that important? Because if we have any fracture in these bones, then you're probably more susceptible to brain injury, because we know above our frontal bone, we have the frontal lobe of our brain, right? So this is just like clinical importance for these walls, or for these bones specifically. And then we have the zygomatic, the palatine, and the maxillary. They come all together to form the floor of the orbit. And any damage to the floor would cause the eye and basically all of the contents of the socket to herniate or fall down into our maxillary sinus. Because right in here we have the maxillary sinus, which is basically, pretty sure you guys covered that. Sinuses are just like air-filled spaces in our bones. So the eye would herniate and go down, or the contents of the eyeball and the socket would just go down there. Tamam? Then we have the medial wall, which is made up of the ethmoid and the lacrimal bone. And then we have the lateral, which is made up of the sphenoid and the zygomatic. Last but not least, we have the apex, which is basically done by the optic canal. And in the optic canal, what goes out there is basically the optic nerve. Tamam? So that's about it for the, what is it called? The bones that make up the orbit. And then we're going to go talk about what do we have inside this orbit. So inside the orbit, we have multiple structures, like the extraocular muscles that help move our eyes. We have the nerves that innervate the eyes, the muscle, and everything that is in there, all right? We have blood vessels that will provide blood. We have orbital fat, because if you think of it, the eye is a very squishy organ. It can be easily damaged, and the bone is just hard. So we would need something to cushion and take away the hardness of the bone, and that's usually done by the orbital fat. Tamam? And all above that, we have the eyelids that you guys have. So basically, the eyelids are the outermost, let's say, part of the orbit that kind of covers everything that's just behind. تمام. هلا we're going to talk more about the extraocular muscles, so I'm not going to talk about them here. But for the nerves, we have multiple nerves in here. It's just literally, so they all have to do with the eye. Optic is for vision. Then we have the oculomotor, which basically helps in the movement of the extraocular muscles. We have the trochlear, which does the same. We have the trigeminal, which has nothing to do directly with the movement of the eye, but it passes through there, and I think it has to do with the parasympathetic and sympathetic innervation. I'm not sure though. And we have the abducent. All right. Then for the blood vessels, we have the artery and the vein. So the ophthalmic artery is there to supply the eye and all the structures and the muscles. And then we have the superior and inferior ophthalmic veins just to drain it out. All right? Perfect. Now there's a very important basically openings in the okay, so as you guys can see here, wait, let me see if I can. Okay. So I want to draw 1 second. Okay. So can you see this area right here? So this is basically a fissure in the bone. So it's like a space that allows for the entry and the exit of very essential nerves and like other structures, all right? So we have the superior fissure, and then we have the inferior, and then we have basically the optic canal, okay, which is kind of easy, but yeah. And the optic canal, from the name, it only has basically the optic, what is it called? The optic nerve, tamam? So again, we have the optic canal that has basically the optic nerve and the ophthalmic artery. That's important. So optic canal has optic nerve and ophthalmic artery. And it's just really easy to like kind of find. It's just literally a small circle into the bone. And then we have the superior orbital fissure and the inferior orbital fissure. And from what you can see right here, oh, I can just draw from here, never mind. Okay, so superior orbital fissure is all of this, all right? And it has all of these structures. So it has the lacrimal nerve, it has the frontal nerve, it has the nasociliary nerve and abducent. It has what else? The inferior division of the oculomotor nerve. So we have basically lacrimal, nasociliary. So it kind of, and if you guys think of it, it kind of like works. So nasociliary has to do with the nose. Lacrimal has to do with basically the lacrimal duct or the tears. So they're all structures that are right here. So lacrimal, nasociliary, and then the frontal, because we basically have the frontal bone right here, so it would have the frontal nerve, right? Abducent nerve, because it has to do with the movement of the eye. And we have the trochlear, which also has to do with the movement of the eye, and then the inferior division of the oculomotor. So basically all of the nerves that have to do with extraocular eye movement. So inferior, what is it called? Inferior division of oculomotor, trochlear, abducent, and then we have just the nasociliary, lacrimal, and that's it. And the frontal, because in the frontal, like we have the frontal bone right here. So all of these are found in the superior orbital fissure, all right? And apart from the nerves, we have one vein, which is the superior ophthalmic vein. And it's kind of easy because superior fissure will have the superior ophthalmic vein. Okay, so again, what do we have in the superior orbital fissure? The lacrimal, the nasociliary, trochlear, abducent, oculomotor, frontal, and then we have the superior ophthalmic vein. Tamam? And then moving on to the inferior orbital fissure. Inferior orbital fissure right here is going to have the zygomatic nerve, it's going to have the infraorbital nerve, and it's going to have the inferior ophthalmic vein. So everything that's kind of down. So we know that basically, so we said we have the frontal bone here. So we have the frontal nerve. What bone do we have in here? We have the zygomatic. So we're going to have the zygomatic nerve, all right? So zygomatic nerve, inferior ophthalmic vein, because it's the inferior fissure, and infraorbital nerve. And it's just the orbit, and it's kind of inferior, so infraorbital nerve. Okay, I'm just trying to kind of do associations so you could memorize them. Okay, these contents are really important for your OSP. They're really important for any injuries that they might, like the questions, they might be like, oh, the superior orbital fissure, like, yalla, what are the contents? I'm pretty sure you're gonna get like an OSCE question about this because I remember we had such an OSCE question, all right? Perfect, so these are everything in here. So we have a mnemonic for the nerves that pass through the superior orbital fissure, and basically the mnemonic is live frankly to see absolutely no insult. So live is for lacrimal, remember, lacrimal. Frankly is for frontal, because lacrimal is for the eye, the tears, frontal is up, so frontal. And then we have to see absolutely. So T is for trochlear. S is for basically a division of the oculomotor. A is for abducens. So those three are for the movement of extraocular muscles. And then we have no for the nasociliary, and insult is for the inferior division of the oculomotor nerve. So basically we have both divisions in here. And the other one we did not. But in المهم, oculomotor nerve, superior and inferior, is going to be there. تمام? Is this clear? I think it's clear. So this is just like a fast summary that I did from ChatGPT that can kind of just come on, just revise everything for you. So optic canal, optic nerve, and ophthalmic artery. Superior orbital fissure, the live frankly to see no, what is it called? No insult. So again, lacrimal, frontal, trochlear, superior division of oculomotor, abducent, and then nasociliary and inferior division. All right. You can just memorize it as oculomotor, ما ضروري superior and inferior in my opinion. I don't know why they're just saying that, but whatever. And then we have the inferior orbital fissure that has basically the zygomatic branch of maxillary nerve or the zygomatic nerve, okay? And it has the infraorbital vessels, okay? Nasolacrimal canal drains the whatever, these are not important, all right? Now, we talked about the walls and we said the walls are important. Why? Because we have different kinds of orbital fractures, right? So for the different types of orbital fractures right here, we have something called orbital rim fracture, and the rim is anything around the edges of the orbit, all right? So this is basically an orbital rim fracture. It can happen either here. Usually it happens in the sutures or the outer edges of the bony orbit. That's why it's called the rim, okay? And then we have something called a blowout fracture. And for a blowout fracture, from the name, blowout, so something's gonna go out of its own place. So we're going to have things herniating from the orbit into basically nearby structures. So as we mentioned earlier, if the floor of the orbit was damaged, we're going to have the contents herniating down into the maxillary sinus, صح? If they go basically up, they might go to the ethmoidal or the frontal, depending on the place of the fracture. And now any like wherever it goes, it could lead as well to basically blowout fractures, they affect the medial inferior wall, causing them to go to the maxillary and ethmoid. We just mentioned that. تمام? هلا complications. So basically, when we have these fractures, what happen can basically we can have herniation like we can see here. So the floor is gone, everything is going all the way down into the maxillary sinus. Okay, or basically, we can have because of let's say, so because of the edema and the inflammation, we can have exophthalmos because the intraocular pressure is just gonna increase, and this is going to cause basically the eye to protrude. And you can guys see this clearly in here, and I'm pretty sure you took exophthalmos before. And under repro, thyroid disease, we have exophthalmos. If there is any injury to the eye, it might cause exophthalmos. Tamam, it's just basically protrusion of the eye. Now, the ophthalmic artery, honestly, I'm just going to go over this really quickly. Just know it's a branch of the internal carotid. It goes through the optic canal, as we mentioned earlier, and then it goes into, what is it called? It goes all the way around the optic nerve, okay? And then what does it do? It basically supplies blood to the orbital content. So it's just the only artery there. And it has multiple branches, and I'm not sure صراحة what are they expecting from you. بس I think you have to know the different branches, okay? وبس هيك تمام. This is everything about ophthalmic artery, nothing much to say. Inferior ophthalmic vein, come on, it drains the orbital contents, it passes through the superior orbital fissure. We mentioned that before. What does it do? It drains into the cavernous sinus, and the cavernous sinus is really important. Why is the cavernous sinus important? Because the cavernous sinus is close to the brain. So if we have any infection there, it can cause really, really serious complications. Tamam? Those are not important in my opinion. هلا moving on into the extraocular muscles. Okay? أول شيء عنا levator palpebrae superius. Okay? Or LPS. Now the levator palpebrae superius, you can literally see it right here. So basically, what does it do? From its position, you could tell that it literally elevates the eyelid لفوق. Okay, so it elevates it upward. What is it innervated by? It's innervated by the oculomotor nerve. So you have to keep in mind, if we have oculomotor palsy, what's going to happen? The elevation of the eyelid is gone. That's why we would have ptosis. So basically the eyelid would be kind of down. Come on. Superior tarsal muscle is it's like a smooth muscle component, all right, in here. And basically it helps in the elevation of the eyelid, as you could see. And it's innervated by the sympathetic nervous system. Okay. And why is that important? That's a very, very, very important detail. Okay. لأنه sympathetic nervous system, when it's dysfunctional, like in Horner syndrome, we have a damage to the sympathetic trunk. What happens is we're going to have partial ptosis. And why do we have this partial ptosis? It's because of the damage to the sympathetic nervous system that supplies the superior tarsal plate. تمام? Is this clear?
Yes.
Okay. Okay. Now, let's go into the rest of the extraocular muscles. So, how many extraocular muscles do we have? We have 6. Tamam? And I like this image because it kind of gives everything. It gives you the different. Okay, wait, let me just remove this. Okay. So it gives you the different muscles. So we have superior oblique. Oh my God, what did I do? Okay, can you see my screen? Wait. Can you see my screen?
Yeah.
Oh, okay. Okay, perfect. All right. So basically, okay. So this is like an amazing photo because basically it has all of the different muscles, the 6 extraocular muscles. It shows you how we can clinically test them and the muscle actions. So we have basically superior rectus, we have medial rectus, lateral and inferior. And then we have a superior oblique and an inferior oblique, okay? And basically the function is just, you could think of it by yourself. So basically superior oblique, if we contract it, what will it do? Sorry, not the oblique, sorry, the superior rectus, this straight one. So if I retract it up or contract it, what happens is basically we're going to have elevation, right? Because it's just elevating it. So easy. So inferior rectus opposite. So it's going to depress it. تمام. So عنا superior rectus elevate, inferior rectus depress. تمام. And then we have medial. Okay, this is not medial, this is lateral. No, that's medial. Medial and then lateral. Okay, so because the nose is right here. So medial is going to cause, so when you contract it, it will cause the eye to look into the nose. So this is basically adduction. So you're adducting it. So the eye is being adducted towards the nose. And then the lateral rectus is going to do the opposite thing, which is basically abduction. So look, the superior rectus elevate, inferior rectus depress, and then left or lateral, sorry, not left. Lateral rectus is going to cause abduction, and the medial rectus is going to cause adduction. Okay? Is this clear? I think it's clear. And then we're going to have the superior oblique and the basically inferior oblique. So basically oblique is going to take it in the other way. So look at this, wait, let me just erase everything so it's clear. So let's look at the superior oblique. Now, what will the superior oblique do? So the superior oblique is attached right here. So if it pulls, it's kind of gonna cause the eye to kind of depress but look down. Do you get what I mean? So basically superior oblique is gonna cause the eye to look downwards like this. Because when you push to that way, the eye is gonna, so it's like a bowl, like a ball, okay? And then when you push it like this, so let's say the pupil is here, it's gonna look down. So it's kind of, it's called intorsion. Intorsion, because basically you're going to look into the basically, how can I say it? Intorsion, like the eye is gonna look down and into the nose, okay? Because this is the superior oblique, you're pulling it like this, it's going to look down, tamam? Inferior oblique is gonna do the opposite. So basically, the inferior oblique is attached right here. And if you pull it like this, the eye is gonna look up like this. So it's going to look extorsion. So it's gonna look to the side and up. Tamam? So again, inferior oblique, extorsion, superior oblique, intorsion. Tamam? How do we clinically test this? Or like if you want to know if basically a nerve is affected, how do we test this? With the etch. So what you do is you sit, I think you guys took this in pro. You sit across the patient, same level, and you ask the patient to follow your finger and you do an etch and you look at their eye movement. So you look from up, down, like if everything is working fine. So basically if we go up, what are we testing? Elevation. So we're testing superior rectus, right? And if we ask them to look like on that side, look. So basically this etch, so kind of we have it. How do I say it? Okay, wait. It's kind of extorted up. So this is the inferior oblique. And then when you go down, so it's like an etch. We go down, this is the superior rectus. Superior oblique. Why? Because you're looking in the nose. So let me just show you something. Just so I think I confused you a little bit. Let me show you. Basically, this is your nose. Okay? When we're doing the etch, when we go up, so I'm going up. What's happening is the eye is looking up and towards the nose. This is extorsion. So this right here, so I'm looking like here. This is extorsion. So this is why inferior oblique. So the obliques are usually the opposite. So inferior oblique, we're looking up towards the nose. Superior oblique, we're looking down towards the nose. Okay? So this is extorsion and this is intorsion. تمام؟ يعني up هيك لفوق هون intorsion, like in, out, all right? And then the etch, so طبعا after I do this, we're gonna go basically to this, the nose side, the side of the nose. So this is adduction. This is the medial rectus. And then we're gonna complete and go all the way to the other side. So this is my etch, and then I'm gonna go all the way to the other side. This side in here, I'm checking the lateral rectus. Then I go up, just up and down like normally. So superior rectus and inferior rectus. تمام? Clear? هلا. Other than the movements, what's important is basically innervation. تمام? You can memorize two that are important, and then the rest you would know they're all by oculomotor. So basically we all know, I think, the S4, L6. So SO4, LR6. So SO4 means SO is by the trochlear nerve or the nerve number 4. And LR6 is basically lateral rectus, and it's basically number 6. تمام? So basically we have the superior oblique number 4. Tamam, this is trochlear. And then the lateral rectus, this is number 6. So now that we have the superior oblique and lateral rectus gone, everything else is by the oculomotor, which is number 3. Tamam? Is that clear? So just literally memorize SO4 LR6. That's basically how I know it. So SO4 superior oblique trochlear, LR6 lateral rectus, adducent, okay? And then oculomotor is everything else. So if we have the trochlear nerve, if the trochlear nerve is basically injured, how would the patient present? So the patient would present with, so how would the patient present? Let me show you. Let's think of it together. So what would happen is, this is basically a trochlear nerve, SO4, صح? So this is the superior oblique. Okay, wait, never mind. This is the superior oblique. All right. So what happens is, this is no longer functioning. So it's not going to contract. So what happens, everything else is going to overpower it. So the inferior oblique is going to overpower it. So what would happen? So the trochlear nerve, usually, what does it help doing? It helps in intorsion. So it helps us basically look down. And so basically down and in. All right? So if the trochlear nerve is gone, what will happen? The patient will present with an eye that's up and out. So basically it's looking up and like kind of out. Tamam? This is basically the inferior oblique is not going to be overpowered. Nothing is going to balance it out. So it's just going to take the full power and it will cause the eye to go basically up and out. Tamam? This is for trochlear nerve palsy. Abducent, basically abducent, what does it do? It basically causes abduction by the lateral rectus. So how do we abduct? Basically, abduction is just our eye moving away from the nose, so looking to the side. So what happens is, since we can't look to the side, the medial rectus is gone, the lateral rectus is gone. So the medial rectus is going to be the stronger part that's going to take over, and it's going to cause the eye to be adducted. So basically the eye is going to be somewhere here. Tamam? Oculomotor? Any other thing is going to cause oculomotor. So this is basically the H. Tamam. هاي البالسي. So oculomotor, what we're going to have diplopia, which is basically double vision, lateral squint. You can see the lateral squint right here. It's kind of, the lateral rectus is overpowered, so it's kind of like taking it to the side. Why? Because lateral rectus is supplied by, I can't see the, wait, let me, lateral rectus is supplied by, can I say inferior is up and out and superior oblique is down and in? Yes, you can say that. Sorry, I just saw your question. Okay, so basically, the oculomotor nerve, so if we have oculomotor nerve lesion, we're going to have we have a lateral squint and diplopia. Why? Because lateral rectus is unopposed and it's acting and it's kind of pushing it to the side. Come on? We're going to have ptosis. Why? Because of LPS that we mentioned earlier. We're going to have pupil dilation and light reflex loss, because basically the constrictor pupillae inside the eye is innervated by oculomotor. And that's it for oculomotor. تمام؟ And these are the very obvious signs. طبعا الأوكيلوموتر كمان, you can't move the eye لا upward ولا downward, like superior rectus is gone, inferior rectus is gone, medial rectus is gone. You get me? Yeah. But these are like things that are so obvious. It's going to be the ptosis because of the LPS, the lateral squint, the diplopia, and all of these things. Tamam? Moving on to trochlear nerve. Trochlear nerve, just what we said. We just talked about it. So basically, usually the trochlear nerve allows us to look down and in. So what happens is going to look, basically, it's going to look up and out. Tamam? So it's looking لبرا. Tamam? I don't care about these. Now, abducent is gonna cause a medial squint. Why? Because we said in an abducent, what happens is that the medial rectus overpowers it. So it's going to kind of, so the lateral rectus is gone. So the medial rectus is going to be the stronger person in here. It's going to push it into the nose. The moment we're going to have this medial squint. Is everything clear up until now? So yalla, what is this? So basically it's a bit hard, but it's kind of So, okay, let's look. So basically the eye, lateral rectus overpowering. Okay, so lateral rectus overpowering, what is that? So which nerve? 3, 4, or 6? 3, perfect. Yes, it's oculomotor palsy. Now, what about this? So it's basically, we have a medial squint. So the medial rectus is overpowering. 6 has gone bad. Perfect, abducent. Okay, everything is okay up until now? I think, yeah. Okay, perfect. Yalla, let's complete. Now we're going to talk about basically the eye itself. Tamam? So let's look at the eye. You can see this is our beautiful eye. We have eyelids, we have eyelashes, we have basically the limbus, or like this is the area around our lens. We have the pupil, the iris, the sclera. So what is the sclera? The sclera is basically the white area right here. And you can see that it has a little bit of blood vessels like into it, right? And then we have the medial and the lateral canthus, which is basically these openings right here. Basically allowed for the movement of the tears. So again, here we have 1 is the sclera, which is the white thing. 2 is the cornea. 3 is the iris, and 4 is the pupil. So there is a lot of like misconception that pupils are basically, I don't know if it's like wide, but and I always thought, the pupil is the colored part, but actually the iris is the colored part and the pupil is just the black part. Okay. And the cornea is basically the bulging out of the eye. So basically, if you look at someone's eye like closely, you could see basically a very clear area that's going up, and that's the cornea. Well, so our eyelids. What are the eyelids made up from? So the eyelids basically have the skin, subcutaneous, ignore the loss, subcutaneous connective tissue, voluntary muscle, tersofacial layer, and the conjunctiva. So basically, this is the skin. And then underneath that, we have basically the subcutaneous connective tissue. Then we have voluntary muscles. What are the voluntary muscles in our eyelids? Basically, the ones we talked about, the LPS, the vater palpebral superior. We have the tersofacial layer. The tersofacial layer is somewhere in here, and then we have our conjunctiva, right? Um, so this is Kaman a more so this is basically more like anatomy of the eyelid. So we have the skin right here, and then we're going to have I'm sorry, wait 1 second. Okay, so basically we're going to have the skin right here, and then beneath the skin, we're going to have the orbicularis oculi muscle. So this is another voluntary muscle. We're going to have the superior tarsal plate, we're going to have sebaceous glands, and below the sebaceous glands, eventually we're going to have the conjunctiva, all right? So these are the orbicularis oculi. Orbicularis oculi are basically the levator P is supplied by sympathetic, right? No, levator P is supplied by oculomotor. But the superior tarsal, we talked about it. Wait 1 second. Let me show you. So the superior. Okay, look in here. The superior tarsal plate, okay, or the superior tarsal muscle is the one that's supplied by the sympathetic nervous system. And it's kind of part of the levator palpebral superior, but levator is mainly innervated by oculomotor. Okay, is this clear? Okay, perfect. Let's go back. Okay, so the orbicularis oculi is basically the one that's around our eye, and it closes the eyelids, all right? And it's innervated by the facial nerve. So if we have facial nerve palsy, what happens? The eyes stay open, okay? If we have oculomotor palsy, our eyes are going, the eyelid's gonna go down, we're gonna have ptosis. Okay? Is this clear? بعدين عنا the tarsofacial layer. Tarsofacial layer, basically they're ligaments, they anchor the eyelids, they separate the layers, and they kind of give some strength to the eyelids. So we have basically the superior tarsus, we have the inferior tarsus, and these are connected by the palpebral ligament. We have a lateral and a medial palpebral ligament. So they kind of are just there to strengthen our eyelid. They're there to anchor the eyelid and separate the different layers because we have multiple layers, all right? And basically, where we have the glands in the tarsofacial layer. So these glands are called either the tarsal glands or the it's such a hard word, meibomian glands, tamam. So these meibomian glands, basically they're embedded into the tarsofacial layer. And if we have an inflammation in the edge of these meibomian glands, they're there just to kind of lubricate the eye, to help in the secretion of tears. يعني they're just glands that help in like lubrication of the eye. هلا إذا عنا نحن inflammation in the edge of the eyelid and inflammation in these glands, this is called a stye. Okay? But if we have a blockage, all right, if we have a blockage of مثلا a bigger gland like the lacrimal gland, or basically something that's rather embedded inside the eyelid itself, this is what we call a chalazion or a cyst, tamam? And it will look something like that. So you see the stye is a bit at the edge, okay? And it's just inflammation. But blockage is called chalazion, which basically, or chalazion, I don't know, but like Dr. Silva says it in a very, very specific way. I'm trying to like, أقلدها بس ما بتضبط. تمام, which is basically it's a cyst. Because there's blockage, it's called a cyst, okay? So a stye is just an inflammation. Chalazion or I don't know how to chalazion. It's just a cyst and it's just a blockage. Okay? So inflammation, stye, blockage, chalazion or chalazion and a cyst. Okay? Perfect. Now we have the conjunctiva, which is the most inner layer of the eyelids, okay? So again, we went through all of them. We went through the skin, we went through the subcutaneous fat or like the soft connective tissue, then we went through the muscles, which is the orbicularis oculi, and the LPS, the one that's the foot. And then we had the the tarsofacial ligament and what is it called? The meibomian glands, and now we have the conjunctiva. Now the conjunctiva, it covers the sclera, which is this white area. It attaches to the sclera cornea junction. So basically, the sclera cornea, that's where the conjunctiva is. And basically, it kind of like folds upon each other. That's why we kind of have superior and inferior fornices. And we can see them like, wait, let me show you here. Okay, so right here, you can see how it kind of closes upon itself. So we have, this is the palpebral conjunctiva, and this is the blue one is basically the bulbar conjunctiva. And they kind of like, you see how like they kind of close upon each other. And because they close upon each other, we have a superior fornix and an inferior fornix, tamam? And it kind of just protects the eye. So basically, if we have any object that goes into here, it can either end up in here, and that's when you kind of feel like itchy and like you kind of like, you know, try to remove it. So it's end up probably either in the superior and the inferior fornix. Tamam? We have 3 different layers. We have the ocular, we have the fornicial, and we have the palpebral. So basically, the ocular is just the one that's the bulbar or like the one on the cornea. Okay. And then we have the palpebral, which is basically the one that is on the sides, and the fornicial is just the fornices, okay? So as we can see here, palpebral is the one that's like basically, wait, let me just erase because it's too hectic. Okay, so the palpebral is just the one that's like kind of underneath the eyelid, and then we have the bulbar or the corneal or the ocular, which is the one that's on the cornea. And then the fornicial is just the fornices that is formed because again, it's like folding upon each other. Clear? I think it is clear. Okay. هلا we're going to talk about the lacrimal apparatus. So the lacrimal apparatus is basically the thing that causes the tears. It's made up of lacrimal glands, ducts, caniculi, sac, nasolacrimal duct. We have anterior and supraorbital, supralateral orbit. So with like, wait, let me show you right here. So in here we have the, okay, let's look at this. This is the lacrimal sac. Sac as like a bag. So lacrimal sac, and then it gives out the canaliculi. So basically canaliculi are very tiny, basically tubes that will open up into the eye. And this is the puncta where basically you could see the puncta in your, like if you look, take your eyelid like down, you could see like two white openings and these are the puncta. And then this sac is gonna go down into a nasolacrimal duct. Okay? Um, I don't care about this صراحة. This is basically the lacrimal duct. This is the كمان nasolacrimal, like wait, let me just double check something. So sorry. This is a better image. I kind of like this more. Yeah. So this is the lacrimal gland. It's the one that secretes stuff. And this is the lacrimal sac, the caliculi, the nasolacrimal duct, and so on. Also, I think it's clear. So this is the innervation. So what is it innervated by? It's innervated by the lacrimal branch of the ophthalmic nerve. And يعني صراحة it's lacrimal duct. فيعني obviously it's going to be lacrimal branch of what? Ophthalmic. Why is it the ophthalmic nerve? لأنه the ophthalmic nerve is the one that's the closest in here. Like it's close to the eye. So ophthalmic nerve. Okay, so ophthalmic nerve is the nerve تبع eye. Okay. So it will give off lacrimal for lacrimation. تمام. The parasympathetic comes from the facial nerve. And that's why if we have facial nerve palsy, what would happen? We're going to not be able to secrete a tear. We're not going to be able to have tear formation. Oh, sympathetic is by postganglionic from the superior cervical ganglion. Guys, this is just memorization صراحة. يلا, tear drainage pathway. So basically, you see this puncta that I was talking about? Like if you open your eyes, you can literally see them. They will go into the canaliculi, into the nasolacrimal sac, and then they will go through the duct into the inferior meatus in the nasal cavity. And that's why when we cry, we sniffle a lot. So basically, they're gonna go from the puncta. Okay, so basically lacrimal gland. Okay, wait, let me show you. Make it more clear. We have the lacrimal gland. Lacrimal gland will cause the tears to form. These tears are going to go through the lacrimal ducts. عندنا multiple lacrimal ducts. So هدول الtears حينزلوا هيك. They're gonna go find the puncta. Okay, from the puncta, they're gonna go into the canaliculi, into the sac. From the sac, they're gonna go all the way down into the nasolacrimal ducts. And it's called nasolacrimal, so feed nasal. So it will go into the inferior meatus, and that's why we sniffle a lot. هلا, babies, sometimes they have issues with their nasolacrimal duct. تمام? They can have nasolacrimal duct obstruction. And this is called dacrostenosis. Okay? هلا, dacrostenosis can be really bad, or they need to usually get they need to kind of open it up using, so basically what they do is they kind of go through the puncture and through the thing with a probe and try to just ease their way into it. High in kids. But adults, they usually do a surgery where they kind of create a whole new opening for the basically drainage. تمام? Dacrocystitis is basically the inflammation of the lacrimal gland, because cystitis is just an inflammation. Dacro is everything that has to do with the lacrimal. Cystitis is just the cyst itself inflamed, and you could see it right here. تمام? So basically this is lacrimal duct or lacrimal cyst inflamed. So I think everything is clear up until now. What do you guys think? Any questions? It's clear. تمام. هلا, moving on. Let's move on. Okay. Now we're gonna talk. Yeah, sure. What's your question?
I have a question. Does
Yes.
the lacrimal part of the ophthalmic join the parasympathetic part of the lacrimation thing? Yeah, that's the question.
So
يعني does it join with V1?
هلا it does. It's part of V1.
لا, I mean مثلا from like the facial nerve. Does it
طيب.
join with V1 to have you يعني start tearing up?
Ah.
كذا لأنه أتذكر there was something in the lectures إنه it goes or joins it ومدري إيش.
Like honestly, I have no idea. I
Okay.
haven't through that idea. فأنا not gonna tell you يعني something وبعدين يطلع غلط. I can look up into it and like answer you later. بس I'm not sure.
هو it's just too complicated أصلا so.
No, yeah, like just أنا for me like if I am like in your place and I'm studying for it, I would literally study إنه lacrimal duct, lacrimal branch, بيجي من ال ophthalmic nerve.
إيه
That's
the general.
you know like the very general because I don't think they
إيه
would
true.
like
It's
that.
too detailed.
Yeah,
تمام.
it's detailed and like I would for nerves and like pathways and all of these things, I think they would go into other like other more important nerves, you know, like facial nerve مثلا, or they love
إيه
the different
true.
branches of the facial nerve وهيك. تمام.
تمام, got you,
I
thank you.
hope ما يكون في ضوضاء حوالي. Do you hear like a lot of sounds behind me or is it okay?
لا, that's okay, it's okay.
Okay. تمام. هلا okay, now we're going to talk about the eyeball itself. Okay, we've been talking about everything around the eye. We've been talking about the eye socket وكل القصص. Now we're going to talk about the eyeball itself. So I don't know why the images are not clear. It's kind of pissing me off, but it's okay. تمام? We can يعني deal with it. So first of all, the very first layer is basically this clear layer right here, and it's called the cornea. تمام? So from the cornea, يعني هنا مثلا we're going in cornea, then we have the anterior chamber, and you can see it in here. So basically, the anterior chamber is what kind of gives us the like the curve of the eye. So basically, if you look at your friend's eye, you could see that it's curved. This is basically the cornea and the anterior chamber. The anterior chamber basically has aqueous humor, tamam, and this aqueous humor is basically, as we said, another thing that kind of like bulges it out. وكمان it provides all of these structures like, you know, the nutrients it needs and so on. And then we have, this is the anterior chamber. بعد the anterior chamber, we have this and this. This is the iris. And then we have our pupil right here. And then at the back, we have the posterior chamber. تمام. And then we have the lens. So again, cornea, anterior chamber, we have the iris, pupil, posterior chamber, and the lens. تمام. بعد the lens, we have the vitreous chamber. Okay, and this vitreous chamber right here, it's basically just a chamber that has a lot of vitreous humor, which is basically what literally makes the shape of our eyeball. تمام. وطبعا we have a lot of other things like the ciliary bodies, the what is it called? The retina, the choroid, the sclera, but we're gonna talk about all of these, don't worry. هلا I'm pretty sure Dr. Salwa talked about this because نحنا in fifth year she made us like summarize all of these things and like just literally what is it called? Not summarize, repeat after her. So basically the cornea, it has 5 layers. What are the 5 layers? Epithelium, Bowman layer, stroma, the membrane, and then the endothelium. Okay. This was not in the lecture, by the way. This was in the physiology lecture, but I included it right here because I'm pretty sure Dr. Salwa loves this. Okay. Next. So this is basically what I've just mentioned. Anterior chamber, it's between the cornea and the iris. Posterior chamber is between the iris and the lens. The pupil is the central opening. Aqueous humor, it's basically the aqueous humor starts, so it's produced in the posterior chamber, but then it goes all the way into the anterior chamber. تمام? So basically, let's go through here. So in here we have basically the ciliary body, and the ciliary body is what basically secretes this aqueous humor. It starts from here and then it goes all the way into the anterior chamber. تمام? Why is it important? It's important because we have the cornea is avascular. What does avascular mean? It has no supply from blood, like blood vessels. So it's avascular and that's why it kind of needs nourishment, and it needs a lot of, like, everything that would keep it vital. A lens, it sits between the anterior and posterior segments. It's transparent, biconvex. It's a disc, blah, blah, blah. It's attached to ciliary muscles. And طبعا, why are the ciliary muscles important? Sorry, ciliary muscles, because basically later on we're going to talk about accommodation, which allows us to look at things in nearby and away, okay? It plays with the shape of the lens. Yeah, exactly, accommodation. And then we have the vitreous chamber and the vitreous humor. So basically it's the very, like, the thing at the back of the eye, and it's basically all made up of, like, a liquid, which is basically the vitreous humor, which is kind of gelatinous, like it's like a gelatin. And as I mentioned, it helps maintain the eye shape. So that's what gives us our eyeball shape. Now, we mentioned the cornea and we mentioned the lens. So basically in the, sorry. Yeah, we mentioned the lens and we mentioned the, basically the anterior chamber and posterior chamber and everything. So إذا كان عندنا opacities in the lens, or basically we have, let's say, calcification or any problem in the lens, it would show up as this guy having a cataract, okay? And in here, تمام طبعا cataract has many different reasons. يعني مثلا diabetes can cause cataracts, like, like so many different things can cause cataracts, but all you have to know is that if we have opacities in the lens, it is a cataract. تمام. Next is basically, we talked about the aqueous humor, right? We said the aqueous humor is made in the posterior chamber. It goes into the anterior chamber. هلا إذا عندنا disruption بالproduction or in the reabsorption, because basically what happens إنه aqueous humor is going to be like produced by it's going to be produced by all of these different اللي حكيناهم ciliary bodies. They're going to produce all of that. بس what happens is إنه إذا كان عندنا a problem in either production, يعني overproduction, أو إذا كان عندنا problem in reabsorption. So basically, let's say there's a clogged, because basically we have like a whole way of like drainage, تمام? If this drainage was blocked, what happens is إنه we're gonna have something called glaucoma, and glaucoma is just basically the eye is basically, يعني the aqueous humor is just like piling up, and it's causing the eye to become really hard and it's really painful. We have to have an open angle, close angle, and I'm pretty sure you guys went over this in the clinical. This is nothing for me to say. هلا, the layers of the eye. تمام. Let's look together. So what we're saying about the layers of the eye, we finished basically خلصنا everything that's out, like from the outside. Now from, let's say, kind of from the back or from the inside, what we have is we have an outer fibrous layer, which is basically the sclera. هلا the sclera, it goes all the way from يعني backward all the way into the front, and that's basically the white area that you see. تمام? And then we have the cornea. We talked about that. And after the sclera, we have the choroid or the vascular layer. Now, the choroid, from the name, it has basically the choroid plexus, it has all of the vascular, like everything that provides the blood. تمام? وبعدين anterior, it's basically continuous with the ciliary body, and we said the ciliary body, what does it do? It releases the aqueous humor. تمام? And then we have retina. Now, the retina is the basically neural layer. It is the place where we have all of the different kinds of cells that helps us see, blah, blah, blah. We're going to talk about all of this. تمام? هلا, ciliary body, again, we said it's basically zonular fibers. They attach to the lens. They form the suspensory ligament, which hold the lens in the place. Okay. Okay, wait. This is the ciliary muscle. Okay, wait. This is ciliary muscle. So the muscle, okay, is basically the one that's attached to the lens. So طبعا they cause the lens either to come like that, يعني to kind of constrict or relax. تمام? So it's either going to become more round or it's going to become like this. And this is for accommodation. We're going to talk about it later بالphysiology. Wait. أنا عم أقول إنه ciliary body is the thing that releases the aqueous humor, but let me check something. We can talk about this later. تمام. هلا, iris, okay, iris, it's basically This is the iris. Now, the iris is made up of some circular muscles and radial muscles. The circular muscles and the radial muscles are the things that would cause the pupil either to constrict or contract. Sorry, constrict or dilate. Contract or dilate. Constrict or dilate. تمام؟ هلا circular muscles, okay, if you look at it, circular are going to cause basically the pupil to constrict. ليه؟ لأنه circular are, so basically this is the pupil, okay? Now the circular are kind of like just making it smaller, okay? So when they contract, they're just gonna make it smaller. While radial, okay, if you see the radial muscles, they're right here, they kind of push the pupil لبرا, which kind of dilates the pupil. So circular constricts, radial dilates. تمام? One is basically what is it called? One of them. So the circular muscles, circular muscles which cause constriction is innervated by the parasympathetic, because basically the parasympathetic, your feet and what is it called? Rest and feed and rest, something rest and something. No, it's basically for resting, and you're not. It's not fight or flight, okay? So because you're resting, you don't need a lot of light to go into your eyes to kind of see what's going on. So it's just like you chilling. So the eyelid is basically, the pupil is basically constricted. تمام؟ هلا. The iris works to constrict, dilate the pupil, and the ciliary works for accommodation. Yep. So basically, iris is there. So the iris has the circular and the radial muscles, which are the ones that would either constrict or they would constrict or dilate the pupil. حلو؟ هلا ciliary muscles, they're attached to the lens. Now the lens is there for accommodation. So the lens is the thing that would accommodate and can I see well, or can I see like a close object or a far object properly? While iris, which is surrounding the pupil, it has basically circular and radial muscles. Is that clear? Clear. Perfect. So, okay. So what is it called? Let me see. Okay. Okay. So so we were saying circular muscles, they constrict. Why? Because basically rest and feed or whatever. I forgot there was something called rest and seat. It was like something. But the radial muscles, they do the opposite. They dilate. It's in flight or fight. It's sympathetic. So basically, if I'm running away from a bear, I have to like literally see everything properly. So I need the most amount of light to go into my eyes so I can see everything. Rest and digest. Okay, thank you so much, because my brain was like, what was the other word? Anyways, so yeah, for parasympathetic, rest and digest. Sympathetic, what is it called? Flight or fight. So in flight or fight, what would happen? Dilation. So dilation, radial. صراحة, if you look at the way they look, you could see it. Literally circular. When they contract, they're gonna cause the pupil to constrict. But the radial, when they contract, because they're like straight lines, they're going to pull the pupil. هيك يخلوها كبيرة. تمام? I hope it's clear. And I hope the people are not noisy around me. Anyways. Now we're gonna go to the retina, okay? So retina is the neural layer, تمام? By neural layer, I mean basically we have all of the rods, the cones, all of the cells, and then we have basically the choroid, بعدين we have the sclera. This is just like the revision. بس معناتها عنا retina, choroid, and sclera. And everything basically at the end, we're going to have basically the optic nerve. So basically everything is going to go merge all together into the optic nerve, and it will go leave. And basically in here, the point where basically the optic nerve is going to leave, it's called the optic disc and the blind spot. It's basically the spot where we see nothing, our blind spot. هلا الretina is the innermost layer of the eye. Mentioned that. Retinal layers عندنا outer pigmented layer, okay? And we have the inner neural layer. So basically, this is important because now when we talk about the vision, it's something that we have to keep in mind. So we have an outer pigmented layer. And why is it important? So we have in here is the outer pigmented layer that's attached to the choroid. So we said إنه عندنا sclera, choroid, retina. صح? So this pigmented layer is attached to the choroid. تمام? And then the inner neural layer basically has the photoreceptors. هلا pigmented layer is important because نحن when light hits the retina, okay? So we have a bunch of lights hitting the retina. We need something to like kind of absorb the extra light. So يعني when you look at the light, okay, we have millions and billions of rays going inside. So they're going to hit the photoreceptors, but at the same time, they're going to hit everywhere else. So we need something that's going to absorb all of the extra light and kind of focus the important light into the photoreceptors. So this is why we have a pigmented layer. تمام? And then the optic disc, as we said, it's the area where we exit the optic nerve. So the optic nerve بتطلع هون. This is the optic disc. تمام? And the central retinal artery branches are literally originally there. And I'm pretty sure in the clinical, you've seen a bunch of photos of the optic disc or a bunch of photos of central retinal artery. Was a kind of hemorrhage. How would it look like? Blah, blah, blah. Then we have طبعا the optic disc is called the blind spot. Why is it called the blind spot? Because basically we literally have no photoreceptors there. We see nothing there. تمام? It's just literally basically the place where the optic nerve leaves. Then we have the macula lutea. It's just, I don't know, يعني صراحة it's basically the central depression where we have the fovea. طبعا the fovea is really important because it's the area where we have the maximum quality of the photo. Why? Because it's the place where we have the most cones. تمام? We're going to talk about this later on. So it's the thinnest region of the retina and has highest visual acuity and sensitivity. Hello? This is just a revision of the different layers of the eye. So this is the fibrous or the sclera, and then it becomes the cornea in here. Then we have the choroid, مع ciliary body, مع what is it called? مع iris, and then we have, last but not least, el retina. Now, to the horrible part of all of this, which is the physiology. صراحة anatomy is easy. Anatomy is super easy, and I'm pretty sure Dr. Salwa in clinical repeated it like a bunch of times. وهيك بس هلا we're gonna go into physiology which is literally physics. Like عن جد أنا عم like revising these things. I'm like, this is physics. Wait, what's the after pigmented layer absorbs extra light to concentrate the light path? Yep. Is this a question or are you like reminding me? Question. Yeah, so basically the outer pigmented layer, what does it do? It kind of مثل ما قلنا نحن عنا كتير like a bunch of light rays. So we have the like basically, okay, imagine these are the cones and the rods, and this is the basically the pigmented area. So the light is going to hit everywhere, 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 everywhere. So any excess is going to be absorbed by the pigmented area, which basically has melanin, which is like the dark color, which is going to just like literally absorb the extra. Will other ones, whatever is absorbed, whatever hits the cones and the rods are going to be like kind of like processed by the cones and the rods. تمام? Clear? Perfect. Now we're going to talk about vision. Do you want to take a prayer break? Yeah, if you guys want to take a prayer break, I don't mind. Like 5 minutes? Okay, perfect. Yalla, let's take a 5-minute prayer break. Um, 1 second. Let me pause the recording. Okay. So now we're going to discuss vision. Tamam? So what is vision? Basically, it's our ability to see. And you might think, no, it's just simple. You look at something and you see it, but صراحة, subhanallah, the way we see things is crazy. Now, first of all, we human beings cannot see everything. The ability, يعني, by everything, I mean like we cannot detect all kinds of wavelengths or all kinds of lights. So we can literally, the visible light is everything we see from here. Like it's literally from the magenta into the like orange. I don't know what color is that. But yeah, you know, like this is everything. This is the only spectrum that we can see. Mom? And basically these are basically the wavelengths that we can detect. But the visual perception is different basically. It's basically what we can interpret from everything we're saying. تمام? And we have different kinds of visions. We have photopic vision, which is basically the daytime vision. We have color vision, which is basically the normal color vision. Scotopic vision, which is basically night vision. We have mesopic vision, which is twilight vision. أهم شيء is basically photopic and scotopic. Scotopic is at night, photopic is daytime. Color vision usually comes with daytime. Nighttime, you don't have any color. And when you're at night and you're trying to like go through your room, you literally see everything is like shades of black. تمام? In here, it's kind of the same thing. We measure light in or the light intensity of whatever we can see in logarithmic scale. Okay, because basically, like okay, we can't detect a lot of light, but basically, its sensitivity is really, really, really like high. تمام? And that's why we kind of like see it through logarithmic scale. Something that's really important, the zero in here, that doesn't mean we cannot see anything or basically it's complete darkness. No, but it's rather just very like minimal light. Okay, يعني مثل لما مثلا you go moon gazing or like stargazing, it's just literally like you barely can see anything. You just literally see dots in the sky. تمام? And then again, scotopic is basically very low light or night vision. So basically it's powered by rods. So rods are the stars in scotopic vision. And usually it enables near darkness or night mode like vision. Again, we said there's no color. Photopic vision is basically done by cones and they allow daytime and color vision. And it allows basically a lot of detail, and we can see that all of these things in well-lit environments. تمام? Mesopic, as we mentioned, it's basically a blend of both. It's we said it's twilight, so basically it's when there is a bit of light, but it's dark. You get me like in dawn or at dusk or in dim lighting. So that's it. And if you can see in here, so this is basically the spectrum. So photopic is usually cones. Scotopic is rods, and this is dark and this is light. And now if we look at the sun, we're gonna have retinal damage because this is just because the retina is overstimulated. We have the intensity is so high that basically it can cause retinal damage. تمام؟ Now, visual adaptation to light. Basically, you know how when you go from a room that is poorly lit into a room that is like well lit. So we're going to have a kind of a change in between the cells that are like dominant in action. So let's look in here. Here it's the opposite. If you go from a room of high light into a room with low lights, what happens is at the beginning the cones are more sensitive. The cones are like over like working and they're like trying to help in like stimulating the image that we see. And then once we go into a room that's really dark, there's going to be kind of a shift from the cones to the rods, and then the rods are going to take over. So, yeah. And this is what we call dark adaptation and light adaptation. Now, dark adaptation, we're going to talk about what happens exactly in dark adaptation. In dark adaptation, tamam, where again we have the rods are more predominant. Basically, the retina is going to increase the sensitivity of the rods by specific things. First of all, our pupils are going to dilate. So our pupils dilate to allow like so basically when you're in dark or like a low dim wait low lit or a dim lighted room, what happens is you barely have any rays of light. So the pupils are going to dilate so it can allow anything to go in, like literally anything, like any ray of light, any like photon just to like go in and so we can see it. Tamam? So that's what happens. So first of all, the pupil is going to dilate. Second of all, we're going to have synaptic changes in the retinal neurons. We're going to talk about these later on, like not very later on, like in a bit. We're going to talk about these. So we're going to have synaptic changes and we're going to have rhodopsin regeneration. So what is rhodopsin? Rhodopsin is basically a pigment. تمام. This pigment is uh, important in night vision. So rhodopsin is basically opsin plus retina. Okay. So we have like kind of in our retina we have like two things called retinal and opsin. So retinal and opsin when they bind together, and this happens usually when it's dark, we're gonna have rhodopsin. Tamam? So rhodopsin is gonna regenerate, and this is going to cause basically improved night vision. Tamam? So we have three things for dark adaptation: pupil dilation, neuronal retinal neuronal synaptic changes, and then rhodopsin regeneration. Tamam? I think it's pretty clear, بصراحة. Personally talking. And then, okay. And then this is basically, what is it called? This is basically a graph that shows the distribution of the cones and the rods in the retina. So we talked like a bit ago about the retina and then how it has the photoreceptors, which is basically the rods and the cones. Now, the abundance of cones is the greatest where at the fovea. Remember how we said like literally 5 minutes ago, the fovea is the place, or it's kind of like a place because literally a dip, okay? And in this dip, we have the highest concentration of cones, and this is where we have the highest visual acuity, and it causes the clearest image to be produced. Tamam? So if you look at the distribution, this is the cones. They're the highest at the fovea. Tamam? And the rods, they're basically higher at the periphery. تمام? So basically the rods are like kind of everywhere around, but يعني they're found all over, but إنه they are kind of just scattered all over. But the cones are concentrated in the fovea. تمام? And this kind of explains why in the dark, تمام, you don't really when you kind of see objects clearly when you're not looking at it. And I think you can like just literally turn off the lights and try to like look at an object, and I think you can see everything around more clearly than the object itself. And it takes time to kind of like, see the object clearly. And this is صراحة so cool, subhanallah. Yeah. And this is just, again, showing you the fovea. So the fovea is just like a dip in the retina. And this dip is just like really, really concentrated with cones, which are the ones that are like supposed to give us the color vision, the daylight, well-lit area. This is what we usually see. Tamam. And you can see حتى انه it's kind of a dip, and it allows the light to directly go to the cone. يعني, you can see how we have ganglion cells in here and everything. But in here, in the fovea specifically, it's just a dip that allows the light directly to go into the cones. تمام؟ هلا, now this is where things get really spicy. Honestly, this part is crazy. Like, أنا for me حتى like it took me some time to kind of remember all of these things. I didn't even study all of this for step one. Like, I had to like do a lot of refreshing. But let's talk about this, okay? So this is the retina. This is the different layers of the retina. You can see the pigment epithelium. Remember how earlier we said, we have the pigmented epithelium, and then we have the basically photoreceptors going out of it. So the pigmented epithelium has basically melanosomes. These melanosomes, as we mentioned earlier, what do? They kind of absorb all of the, let's say the excess rays, the scattered rays, just to kind of focus the light into the cones and the rods. تمام? We have, so here's the photoreceptors, and then we have basically, I'm not sure if you have to know the layers, but I remember إنه Dr. Silva cared about them. I'm not sure if يعني صراحة, I don't know, I didn't go through your clinical to know 100% what you should know and what you shouldn't know. But for me, what I care about is you understand إنه عنا rods and cones, they're in the photoreceptor outer segment, تمام? Then we have in the plexiform layer, we have the bipolar cells basically connecting with the cone, okay? And the horizontal cell, تمام? So we have a horizontal cell attaching to most of them. طبعا the horizontal cell, you can think of her like fine tuner. It kind of like fine tunes everything. يعني هون a lot of things are gonna happen. Horizontal cell is just there to fine tune everything. مثل الأماكرين cell كمان later on. And then we have basically in the inner nuclear layer. So anything that has nuclear layer has cell bodies. So you see مثلا outer nuclear layer has the cell bodies of the cones and the rods. Inner nuclear layer has the cell bodies of the bipolar cell. And then we have the plexiform. Inner plexiform, it's basically when the place where the bipolar is like kind of synapsing with the ganglion cells. And then we have the ganglion cell layer. على فكرة we can memorize them together now. So again, pigment epithelium, and then we have the photoreceptor segment. I don't care outer or inner, خلاص photoreceptor segment. And then we have the outer nuclear layer. Why is it the outer? Because we have an inner nuclear layer. So outer nuclear layer first, بعدين بيجي عنا outer plexiform layer. So the nucleus, بعدين بيجي عنا the area where they synapse. And then we have the inner nuclear layer, and then the inner plexiform layer where basically كمان عنا synapsing, and then the ganglion cell layer. صراحة it's easy to memorize. I don't know if you have to memorize it صراحة, but I kind of like, do you get the way I'm trying to make you memorize it? Or am I confusing you? Okay, perfect. تمام. هلا بعدين آخر شيء very fun thing, all the ganglion cells, they're going to join together. All of the nerves from the ganglions, they're going to join together, form a bundle of nerve, which is basically the optic nerve. Okay. So let's go layer by layer and understand how do we see things. تمام? First of all, we're gonna go to the rods and cone. Hi, rods and cone. So these are the rods and cones. We have, again, they are on the pigmented layer. This pigmented layer, they absorb the stray light and they kind of reduce the reflection. They kind of just optimize the light to reach the rods and the cones. تمام? And then we have something, okay. Then we have something that's really important. Here, basically, how do rods and cones understand light? Or the process is called transduction. تمام؟ صراحة transduction can sound scary, but it's easy. What you have to understand, the fundamental thing to understand in here is that basically, it's funny. The cells themselves, the rods and the cones, they are always depolarized. When there is no light, when we have no light, nothing, no stimuli, اللي هي light, basically, إنه نحن we're talking about photoreceptors. What is basically the stimulus? The stimulus has to be photons or their light. So لما يكون ما عنا, we don't have any stimulus, we don't have light, the cells are depolarized. And why are they depolarized? Because remember the retinal and the opsin that we talked about? We have retinal, we have opsin, so they're binded together. So when they bind together, what do? They kind of cause the cell to release glutamate. So the CGMP is going to be really high. Sodium channels, so literally CGMP levels are really high. Sodium channels are open. The cell is depolarized and glutamate is literally being fired, like fired. This is in case of no light. So think of it like that. No light, glutamate is high, the cell is depolarized. Once the light shine into, so once we bring a light and we shine it into here, what happens is this retinal and opsin, they're going to break up. So the retinal is going to move, the opsin is going to move, retinal is going to change its shape. Well, this is going to cause the glutamate or like the CGMP to like drop. So CGMP gone. CGMP is gone, sodium channels will close. Sodium channels are closing, the cell is hyperpolarized. Cell is hyperpolarized, this means there's no glutamate being released. تمام؟ هلا, this is the transduction. This is the basics of transduction. حلو? What I want you to understand is, no, basically, in rods, okay, عنا rods وعنا cones. In rods, okay, when basically, inside rods, let's talk about the cones. Cones, when light is shined on the cone, that's when it's going to kind of activate the bipolar cell. So light is shined on it. CGMP is low لأنه الريتينال والأوبسين بعدوا عن بعض. CGMP is low. sodium channels are closed, the cell is hyperpolarized, glutamate decreases, that's when it's going to activate the bipolar cell. So that's when it's going to cause kind of a graded potential. That's when it's going to cause something. This is when the stimulus happens. تمام? Is this idea clear? Great, perfect. Okay. هاي أهم شيء. This is like the basis of everything. تمام? So هلا الكونز we have three cones. We have يعني not specifically three, but يعني yeah, هن three cones. We have the red, the green, and the blue. These are basically their wavelength analyzers. So basically, the blue color is literally just a wavelength. The red is a wavelength. The blue is a يعني the green is a wavelength, and then basically, different pigments is just basically I don't know like different wavelengths coming all together. You know like light وكل هذا الwavelengths صراحة وهالأساس أنا ما كتير بفهم فيهم بس like it's such an interesting يعني thing to think of, you know. And basically, any white light we see is basically all these three colors together. Any black color we see is none of these colors, I think, or something like that, or none of them are stimulated. Yeah, I think something like this, okay? Basically, الأوبسن is different in these cones because basically الأوبسن هو اللي إنه مثلا we have three different options and these three different options each are like kind of related to a color, you know, like مثلا the red has, let's call it red opsin. The green has a green opsin. The blue has blue. That's not the actual name, but you get me? But this is how like مثلا the cones kind of detect the color. This is not really important. You just have to know إنه عندنا three cones, they're wavelength analyzers, and that's how they detect the colors. So are we okay? Up until now, is it clear? So basically, when does the cell kind of send a stimulus? When it's depolarized or hyperpolarized?
Hyperpolarized.
Perfect. When it's hyperpolarized. Hyperpolarized means it's not secreting a lot of glutamate, means the CGMP is low. It means that basically, what is it called? The sodium channels are closed. Perfect. Hello. Let's go to the next step. So these are basically the cones. Hello. Hi, there is light. تمام. What happens is they're hyperpolarized, less glutamate. So لأنه عندنا less glutamate, we have bipolar cells. Bipolar cells, so basically from the word bipolar, عندنا on و off يعني مرة on مرة off. Bipolar. Literally, the cells is bipolar. So we have basically something called an on center and an off center. هلا لما يكون عندنا no like decreased amount of glutamate, the on center is gonna fire. So on center is gonna be depolarized. So less glutamate means the on center of the bipolar cell is going to be activated, it's going to be depolarized, and it's going to send a graded potential. Hello? Is this clear? So in bipolar, it's kind of the opposite. When the cell is depolarized, it's going to send a stimulus. تمام? And how is it like depolarized? By basically ما يكون في كتير glutamate. Was this clear? It's opposite for both. What do you mean for both?
Like مثلا bipolar مع ايش اسمها the other one, the other cell.
You mean with the rods? Yep.
Yes. So يعني مثلا if the rod is hyperpolarized it sends. If the bipolar cell is depolarized it sends.
Yep.
Okay تمام.
Come on. Okay. So basically هلا نحن لساتنا we're doing the on. تمام. So what is it called? Wait, sorry. Less glutamate, the bipolar cell is depolarized. It secretes, basically, it causes greatest potential, secretes whatever chemical. تمام؟ هلا so we finished photoreceptors, we finished bipolar cells, now we're gonna go to the ganglion cells because we said it's 3 levels, صح؟ هلا ganglion cells, we have basically this is a ganglion cell. We have something called on center, off surround, off center, on surround. تمام؟ It's like هيك, it's like a circle. Literally the circles in here. So you see basically the on center, off surround. So basically is a مثلا it's on and it punch, so if the light comes into the center, this means the light is on. تمام? So it increases firing. off center إنه if the light is on the surrounding, it will decrease the firing. So on center, off surround. Think of it like that. If the light is on the center, it increases. If the light is is on the surrounding, it decreases. لأنه it's on when it's on center. So on and on increases, on and off decreases. Do you get what I mean? يعني أنا light, I put it on the center. And basically, where am I? يعني the cell, wait, I kind of confused you guys, wait. So basically, I'm talking about this scenario. Number one, hello. We have an on-center of surrounding cell. And I have an light. Wait, sorry. I have light on. طيب. When on center. Light on center. Only center. تمام? So if the light is on the center and it's an on center, so basically what will happen? The firing is going to increase. طيب. If the light is on surrounding and it's off as surrounding, it will decrease. What I'm trying to say is إنه شيلك على light is on center or surrounding. بس عنا light on. Okay, light is on. And we have basically on center, off surrounding. Think of it like that. If the light is on the center, it's going to increase. But is a light on off surround, يعني is a light is on the surrounding, but surrounding says off, so it's going to decrease. يعني is a on and on increase, on and off decrease. Do you get what I'm trying to say? Okay, let me elaborate. So يعني أنا قصدي إنه
Wait, I have a question. مثلا
Yeah.
يعني are we talking about كيف there's one part that's an on well there's another part that's an off.
If the
وإن-
light is on the on part, it increases. But the
حلو.
light is on the off part, it decreases. The stimulus يعني. Do you get
يعني
me?
في إيه فيعني it's two places with
Exactly.
different
يعني look,
functions.
let me show you. يعني let me draw the circle and try to explain.
Yeah.
So what I'm trying to say is, no, I need like a, wait. What did I do? Do you still see me?
You're good, you're good.
Oh, okay. طيب. Let's add an empty paper to explain it. طيب. Let's present. تمام. So what I'm trying to say is we have a cell called on center, okay? This is and then off surround. تمام؟ بعدين عندنا light. Okay? So if the light comes onto the center, okay? So light on center وطبعا it's called on center. So the stimulus is gonna increase. حلو?
Yes.
If this light goes to the surrounding without touching the center, the surrounding is أصلا off. طيب? So basically we're gonna have an on the surrounding, but the surrounding is off. So what will it do?
decrease. Okay, فهمت. I
You-
got it. إيه خلاص I understand this. إيه تمام. It's clear.
Okay. Is it clear?
It is clear. إيه. I get it.
تمام. This is the thing. عندنا two types. واحدة كمان. So another one is called off center on surround. So it's just the opposite. طيب. So هلا تعالوا نطلع على هاي الصورة. Basically, light on center only. So this is an on center cell. So if the light is on the center only, then it will fire rapidly. But if the light is on the off center, it's going to decrease the firing. Do you get me? هلا هون. Okay, هلا هون. Light on surround. Okay, so is a light is on the surround only and it's not touching, so basically on off, it won't fire. But if the light, wait, light on, okay, and it's off surrounding. Wait. There's something stupid in here, never mind. بس فهمتوا الكونسبت؟ بالimage there's something wrong.
الكونسبت إيه خاصة يعني it's there
Get the
موجود.
concept. That's what I care
أيوة it's
about.
there.
Because exactly, فبasically السل. Do you see my camera or no? Because أنا اختفيت من عندي.
لا you're clear.
Okay. So basically we have two cells. عرفتوا علي؟ Is the middle is on and the light goes into it, then it will increase. But as the light does not go into the middle and goes to the surrounding, it's gonna decrease firing. هلا as the light goes a little bit on the center and then a little bit on the surrounding, كمان this is going to cause basically weak firing. تمام؟ يعني إذا عنا the center and the surrounding stimulated at the same time, the response is gonna be weak because you have to have it centered on one area بس. You get me?
إيه
هلا why is this important? Because the ganglion cells are the cells that are going to kind of يعني detect the contrast and the edges. You get me? So it's the thing that's going to kind of give us finalizing للصورة إنه the contrast with edges of the photos and everything. You get me? Or whatever we see. And basically what ganglion cells كمان do, they kind of change graded potentials into action potentials. حلو? So نحنا we had graded potentials, now we have action potentials. So يلا, let's go through what's happening. يعني let's go again through whatever happened. So first of all, light is shined into the cone. What will happen? The cone is going to be hyperpolarized. Why? Because the retinal and the opsin, they left each other, CGMP levels dropped, sodium channels closed, and because sodium channels closed, it's hyperpolarized. So the glutamate decreased. هلا الجلوtamate decreased, what would happen? The bipolar cell, the unbipolar cell is going to be activated. Okay? فالbipolar cell that's on, it's going to kind of fire more and more into the ganglion cell. حلو? And then the ganglion cell, if it مثلا drops onto the on, مثلا let's say it's on center, okay, and off surrounding, and the light goes into the on center, then the firing is going to decrease, and vice versa. You get me? By then, all of these are going to become آخر شيء eventually an action potential that goes through the optic nerve. تمام? Is that clear? هلا for rods, what happened is kind of the opposite, okay? So لما يكون عندنا a lot of glutamate, what happens is the off is going to be activated. And because the off is going to be activated, everything will change. You get me? So in
I have a question.
yes.
We were talking يعني كل المechanism previously was about the cones صح؟
Yeah. بس هلا the same thing applies to the rods. إنه basically when we have more glutamate, okay, هلا هن basically they get depolarized when it's dark. صح?
صح.
So the rods will get depolarized when it's dark. So when it's dark, we're going to have more glutamate. هلا the glutamate is going to act on the off center تبع bipolar cell. So it's gonna kind of like change the pathway into the off center. تمام? So we go into the off center.
Okay تمام.
Off center on surround, okay? Off center, so light is not in the basically center, so it will decrease the firing. فالcontrast أصلا بالعتمة بيكون قليل. The contrast in like dim light is really really low. Do you get me? So يعني in hypothetically speaking, on center off surround is for the cones and off center on surround is for the rods.
It's clear تمام.
تمام?
Yeah.
Okay. هلا we have two ganglion cells كمان. So we have magnocellular cells which are basically large and they're specifically for motion. So M and M, motion, location and depth. Parvocellular cells, they're smaller in size and they're there to kind of see the fine details, the process color, the shape, for texture يعني أشياء like really teeny tiny things. So the magnocellular, the big ones are there for motion, for location, for depth, and so on. The parvocellular is there just for the fine details, the color, the shape, you get me? just know that. تمام. هلا هون let's مثلا revise all of this. So basically this is مثلا how it starts. So the light goes into the center, بيروح لعند الكون تنزل لتحت. Let's say it's depolarized, so the glutamate decreases, so the bipolar cell مثلا is not is activated. It will increase the firing on the on-center. You get me? فهون بصير في عنا increased firing to the optic nerve, so we see مثلا ال edges properly, the contrast is better, and so on. تمام? Is it clear? So this is basically it.
It's clear.
Okay. Next, let's go on. So the visual pathway. Basically, this is basically what we, يعني لهون, this is literally what we said. Photoreceptors into the bipolar cell, into the ganglion cell, and then they're going to go to the optic nerve, optic chiasm, optic tract, and then they're going to go to the thalamus, into the LGN, which is basically lateral geniculate nucleus. هلا, in the lateral geniculate nucleus, this is the place where perception happens in a way. So what happens is everything that we got is going to come into the lateral general nucleus. Lateral geniculate nucleus. تمام? It's kind of a relay station. أصلا the thalamus, I'm pretty sure you guys remember from neuro, is a relay station to every kind of thing, like the emotions, for movement, for I don't know, sensory, everything. تمام? So what happens is, everything is going to relay there. So the parvocellular and the magnocellular pathways are all going to relay there. And everything from the retina to the cortex, everything is going to go there. So all of the information that we have about everything that we're trying to see will end up relaying in the lateral geniculate nucleus, in the thalamus. تمام? And then what happens is basically this is everything that comes from the eye. But كمان a lot of things that are in the brain will command relay there. Okay? So what happens is, يعني it's kind of really wild, but what we see is 10 to 20% of basically stimulus into the retina, and 80 to 90% basically our brain trying to rationalize what we're seeing. So basically I'm looking at this water bottle, okay? يعني 10 to 20% is just the different colors and everything from my eye. And the rest of the image is just my brain saying, oh, this is a water bottle, so it probably looks like this. You get me? But this kind of modulation and trying to create photo, all of these يعني كل هدول signals that will do that all relay in the lateral geniculate body. تمام؟ وحتى كمان things from the مثلا the corticospinal, corticopontine, corticobulbar fibers. يعني مثلا أنا this water bottle, the way it feels, the way it يعني everything, أو مثلا how do I reach to it, all of these signals كلهم, every signal related to the thing will relay وين بالlateral geniculate nucleus. تمام? Is everything clear up until now? I think it is صراحة. And then after this, okay, where did I go? Sorry. Do you see my screen?
Everything is okay. Tamam. It's fine.
Just wait.
I can see the screen or I can see you.
Why can I not see both?
Maybe it's from your side.
Yeah, it is. Oh wait, never mind. It worked, I think. Yay, okay. تمام. هلا بعد ما we finish from the thalamus, we're gonna go to the actual brain. تمام. Where will it go? It will go to we have basically two places. We have the ventral stream and the dorsal stream. تمام. Both of them are in the occipital lobe. Okay. Sorry. I don't mean that. بس إنه wait, we have basically sorry, ventral stream and dorsal stream. طيب. الventral والdorsal, they're going to start يعني they'll go from the thalamus to the occipital, and then they're going to end in different areas. Okay, so you see مثلا this is the what is it called, this is the lateral geniculate nucleus and the thalamus. It will relate to the occipital lobe, and then it's gonna go through pathways اللي هي V1 V2 V3. I don't think you guys have to know the V things, but just know where will it end up. Okay, فعندنا ventral stream اللي هي basically it's called what pathway, or it's basically the object recognition system. So it kind of tells you what you're looking at. So I'm looking at a water bottle. So basically the ventral stream is kind of telling me, Talah, you're looking at a water bottle. So how does that help? It's basically this pathway specifically is there to kind of recognize the shape, to identify the thing, to store مثلا this visual memory. So later on, when I look at the same bottle, I'll remember, oh, it's this bottle, you know? This is the ventral pathway, or the what pathway, or it's basically object recognition system. This pathway ends up in the inferior temporal lobe. That's what you need to know. I don't think you need to know V1, V2, V4. أنا نفسي ما بعرفهم الصراحة. I literally graduated it doesn't matter. Okay, just know إنه ventral pathway. It's the what pathway. It helps us like kind of understand the object. What object are we looking at? And it relays in the inferior temporal lobe. طيب, it helps in recognizing the shape, the object. It's identifying things and basically storing the memory for later on. And then we have the dorsal stream. A dorsal stream is basically the where. So it's basically the motion and action. So where is this object? Where is it going? So basically أنا هاي مثلا the bottle is beside me. So how do I know the bottle is beside me? Through the dorsal stream, the where. So the where, or the dorsal stream, it's for motion detection. It's for knowing where the things are and for guiding the eye movements and hand movements. So basically, because I know the bottle is on my side, if I want to take the bottle, I know how to go. You get me? And it's just like something, it's like, because you know, our brain is just like multiple circuits all working together. What else? And it ends relays in the parietal lobe. Tamam? So the what is in the temporal lobe, as the where is in the dorsal. Okay? I think that's all you need to know. هلا for these, I'll just tell you what I understood and what I think is important, because يعني صراحة this is crazy يعني. We have in the visual cortex, we have different kinds of cells. We have something called simple cell. A simple cell is basically a cell that detects a straight line. Okay? So a straight line يعني مثلا a straight array of light. So أنا مثلا I can see this light. This is my simple cell acting. And then we have something called complex cell. So complex cell is able to see a straight line moving. So if the line is moving, okay, a straight line is moving, شو اسمه? That's what a complex cell would see. So a simple cell is just gonna detect the light. A complex cell is gonna detect the light, the line with the motion. حلو? And then we have the hypercomplex cell, which is gonna detect the line, its edge, and its motion. So it's just like they build it up. Simple, I'm just gonna see a line. Complex, I'm gonna see a line in movement. Hypercomplex, I'm gonna see it in like kind of a 3D, and I'll see the edges, and I'll see the motion, and I'll see the line. You get me? But these cells are there in the visual cortex, and they help us kind of create the full image. How do they do that? I don't think you guys need to know, صراحة, because that's crazy. Is that clear? Okay. Moving on to the last part of this, which is basically the optics. This is the easy part, صراحة. I felt like it's really easy. So, refraction. Refraction is just something we took in physics. Okay? It's basically a light. يعني مثلا أنا when I put this pencil in this water, looks like it's broken or it's bending. Why? Because basically the speed of light in air is different than the speed of light in water. So it's going to cause this image to look distorted, and that's what we call refraction. Why does refraction happen? Because we have something called refractive index. What is the refractive index? It's basically the bending of light as it changes mediums. Hello? Basic physics, literally physics. So basically. وكمان في شغلة we used to take and we used to like graph these. I don't know if you remember, بس إنه we had to like have like a normal line, and then if basically the thing is going from lighter to denser, it's going to bend towards the line. But if it's going from denser to lighter, it's going away from the line. These things are صراحة too physicsy, so I don't think you really need to know this. This is basically the visible spectrum of light for us. We're talking about this again. Not important for now. هلا عنا types of lenses. This is important because if مثلا someone wears glasses, you have to understand the types of lenses because different lenses address different problems. So عنا spherical lenses and we have cylindrical lenses. تمام؟ the spherical lenses are the most common lenses, and these are the lenses that are commonly used in glasses. We have best two different kinds. We have convex and concave. Now, convex is converging lenses. So basically, what it does is it tries to get all the light together to converge into one point. تمام? And basically, these lights, this is the convex, and then we have a concave lens, okay, which is kind of it causes basically the light to go like بيكونوا they're together, and she kind of wants them to disperse away, so diverging lens, so they curve inward and then they spread apart. Come on. هلا الconvex and concave is used to kind of focus the light into a point, okay, either into or outside the, basically we're going to talk about this يعني more in details, but the idea is we're trying to focus the light to kind of address اللي هي myopia and what is it called, what was the other one, المهم إنه nearsightedness and farsightedness. I forgot the other one, but we're going to talk about it. Okay, hyperopia. Okay, so we're gonna يعني so one of them is used for myopia and the other is used for hyperopia. Okay, we're going to talk about these more details in the next slides. And then we have something called cylindrical slides. Now, these are not as commonly used as the spherical, but they are important for astigmatism, okay? Astigmatism is basically people that see, when sometimes you look at a light and then it looks blurry, like هيك حواليها blurry and stuff. This is astigmatism, okay? Okay. Now, exactly. So what do? They kind of focus the light. So basically, we have a lot of lights and they focused into one line. So this is what astigmatism, the main problem is, and we have multiple lines on different axes. So this cylindrical lens is gonna kind of converge them all into one line so you can see properly. And this is what will fix the blurriness and make the whole image clear. So that's all you need to know. And two types of lenses. We have spherical, cylindrical. I don't know why I can't say that word. Spherical and concave and convex. One of them is used for myopia and the other is used for hyperopia, cylindrical is used for astigmatism. We're gonna talk about this كمان moving on. So شايفين this is a this is a concave, I think. Yeah, so this is basically converging lens and this is a diverging lens. Converging, it's kind of converging all of the lights into one point. حلو. On diverging, it's kind of like dispersing the lights all over. And there's something that's really important that we used to take in physics, and it's even important for us in our with this vision. It's basically the focal length. Now, the focal length is basically from the lens up until the point where all the lights are converging, and that's usually where the image is created. Okay. Just keep in mind the focal length. lens power and prescription. I'm pretty sure I don't know if you guys wear glasses, and I don't wear glasses, but everyone in my family does. If you have anyone in your family who wears glasses and you just look at the prescription, it's so weird because it just has plus, minus, weird things. I don't know. Lens power, why does it have the plus and the minus? We're going to talk about this now. So the lens power is basically how strong the lens is in bending the light, because the whole problem is in the light bending, صح? Usually the power is calculated by 1 over the focal length. So the focal length is 1 meter, so the power is 1 diopter, because it's an optical thing, okay? But diopter is a 1 meter. So 1 over 1, it's 1 diopter. 1 over 0.5, it's going to be 2. 1 over 0.1 meter, it's going to be 10. So what we need to identify, basically what optometrists try to do is they try to identify the lens, focal length. Hello? To kind of correct the focal length, or kind of like correct it with the convex or the concave glasses or whatever. Okay? So they calculate this focal length and they use this formula here, power equals 1 over focal length, to figure out the diopter that is needed. Okay? Or the power that is needed لللens, like to correct the vision. هلا عنا الconvex, okay, اللي هي the one that brings the light rays together, اللي هي basically the converging, which is this one. The convex, it's used for farsightedness. So basically, if a person cannot see the farsightedness, what do? They usually, what is it called? They give them convex lenses to bring the light rays together so they can focus. تمام? Is that clear? Is it clear? Okay. So, convex, again, it's used, okay, for farsightedness. طب, does anyone know what does farsightedness mean أصلا? Farsightedness means إنه هن they can see what is far away, but they can't see what's close. يعني مثلا, and this is what basically, in other words, it's hyperopia. So they can clearly see مثلا 10 meters away or like 100 meters away, but they cannot see very closely. And this basically happens كمان إنه when people get older, in a way they kind of, يعني you know how مثلا أنا, my mother مثلا, she recently started wearing just glasses because she can't see the close by, okay? But far, like anything that's far away, she can easily see. So this is what we call hyperopia, okay? And we give them convex, اللي هي converging lenses to fix that. Because in a way, we want to converge the light, converge these things at a place where they can see the close stuff. Do you get me? And the sign is power, because we're converting them, we're bringing them all together. So we're adding things together. On the other hand, in nearsightedness, they can see the close things, but they can't see the far away things. What do? We give them concave or diverging lenses. So they're going to spread everything out. So the far away is kind of clearer, okay? And because we're kind of diverging or like causing the rays to go apart away from each other, it's negative. Huh? This is used for myopia or nearsightedness. هلا, these are so like, I don't know, I useless. So basically this is the object, and then we have 4 refractive surfaces where it goes through. So basically when light goes through, it goes through air, which is, this is the normal, but then it goes through the cornea, and then it goes through the aqueous humor, and then the lens, and then the vitreous. So it has different, so each thing has a different density, okay? So all of these have different densities, and you can see that. So it goes through 4 refractive surfaces. Most of the refraction occurs at the cornea, okay? Which is interesting because you can look at the figures and you could see that the lens has the highest refractive index. Why is it the most? Why is it the most at the cornea, not at the lens? Because basically, if you think of it, the difference between the air and the cornea is 38. Hello? 0.38. And then it goes inside. The difference between the aqueous humor and the lens is not that much. It's just like literally 0.7. So which is stronger, 0.38 or 0.7? أكيد 0.38. Technically speaking, actually this is not 0.7, that's 0.07. You can see why I went into medicine, because physics and math, both of them suck عندي. Anyways, so what is it called? Most refraction, where will it occur? Between the cornea and the air. بس what has the most refractive index? It's the lens. Is that clear? Because I don't mean مثلا if the doctor brings this image and he's like, yalla, where does most refraction occur? And someone just chooses the lens just because it has the highest refractive index. And you're like, oh, high refractive index, معناتها most refraction occurs there. طب okay, it does have the most refractive index, بس يعني compared to the aqueous humor, the difference is really low. You get me? For the refraction is not going to be as strong as a refraction between the air and the cornea. Is that clear? I hope it is. طيب هلا wait, I forgot to say something in here. Now, since we have all of these refractive surfaces and the light is going through all of this journey, people decided, like scientists decided, the refractive power of everything بالحياة is 59 diopters. So it's basically 1 over something that eventually equaled 59. What is this something? I don't know and I don't want to know. تمام? But I'm trying to revise the power thing with you guys. Oh yeah, it's here. It's 1 over 17. Sorry. I just hate physics and math. So the reduced eye schematic model, they're kind of just saying, no, okay, we have 4 refractive surfaces, but you know what? Let's just say إنه نحن عنا one strength or one whatever, okay, which is basically the 59 diopters. And how did they calculate that? They just calculated the length, اللي هي الfocal length. Is it called focal length? Yeah. The focal length, they calculated the focal length from the, 1 second, from the lens to the fovea. This is the focal length. Because basically, if you think of it, all the light is going to go through the lens and then it's going to eventually converge in the fovea. So this is the focal length. And it was 17 millimeters. So 1 over 17 millimeters equals 59. Okay. Plus حتى عملوا another thing that is kind of كمان extra. They went and they kind of got the diopters of each and everything اللي هي الcornea والposterior surface of the cornea والeye, they added them all together. كمان they ended up equal 59. So slay, I guess. Let me just double check if 1 over 17 is actually 59. Imagine if it's not. Wait, 1 divided by 7. Oh no, it is. Anyways, this is all just هلا we have something called the visual angle. And why did I do this? Because I want to show you something that is really okay. So visual angle, what is the visual angle? It's basically the angle that is formed with the basically lens, okay, or the cornea. Actually it's the lens, بس أنا هون لأنه ما قدرت أحطه عليه. Ignore it, okay? So let's imagine this is here. So it's basically the angle ما بين okay, so basically the end and the start of an object. So basically this is the height. So you see this pen. So the end of the pen and the start of the pen. هلا, what I wanted to show you, and that's the reason why I'm trying to, the visual angle changes with distance. So if it's really close, you see how the angle increased. If it's really far, you see how the angle decreased. If it's really big, you see how the angle increased. If it's really small, you see how the angle decreased. So yeah, visual angle is basically the angle between the object and any 2 points that هلا هو 2 points and the lens. وهدول 2 points are basically just the top and the bottom of the object and where it lands. Is this clear? And you have to know that the visual angle differs ما بين size, distance, and these things. Clear? صراحة this is fun. Anyways, I hope it's clear. هلا, why is the visual angle important? Actually, never mind. Okay. هلا, we have something that we okay, so we were talking about glasses. before we kind of go and be like, okay, you need glasses, what do we need to determine? We need to determine visual acuity. What is visual acuity? Visual acuity is basically the sharpness of the vision or the resolving power. I have to make sure that this person's vision is 10 out of 10, like perfect, okay? How do we do this? It's basically the ability to see 2 points as separate, basically just the same idea, and to see the top and the bottom. So the visual acuity, how do we test it? We test it with something called the Snellen chart. And I'm pretty sure everyone who got their driving license, everyone who goes to the ophthalmologist just for a checkup, they always go and check the Snellen chart. This is the Snellen chart. The E, the 4, the all of these things. Hala. The Snellen chart, what does it depend on? It depends on, so basically, it depends on the distance the patient is standing from the chart over the distance where a normal person would see it. يعني مثلا when we say 6 out of 6. So what do هلا مثلا when you see like basically the results that of a person after going to the ophthalmologist and مثلا 6 out of 6, what does that mean? This means in a normal vision. This means no, you were able to see the letter from 6 meters that you were supposed to see at 6 meters. Do you get me? يعني a person with perfect vision is usually sees مثلا this E at 6 meters, and you were able to see it at 6 meters. So perfect. Your vision is perfect because you are supposed to see it at 6 meters. So 6 out of 6 is perfect. But 6 out of 60, يعني 6 meters, you saw something at 6 meters that a normal person sees out of 60 meters. This means your vision is so poor. تمام? 6 out of 5 means يعني mashallah, you see better than everyone. Because 6, you're seeing at 6 meters what person at 5 meters is able to see. Do you get what I mean? So the denominator اللي هو تحت is usually what you're supposed to see it, like the يعني the normal. أنا مثلا that chair, I can see it, I'm supposed to see it from 60 meters away, and I am 60 meters away, so I'm 60 out of 60. So perfect. As long as the denominator decreases and the denominator increases, this means poor vision. The opposite means amazing vision. Okay? Equal means normal vision. Is this clear? I think we lost our soldiers. I'm sorry. Okay. Hello. Let's see here. Basically, if we are trying to kind of put everyone in a chart where we're like, these people are normal, these people are fine. So the normal is 6 out of 6. Hello? Hello. If we saw 6 out of 12, so basically half, let's say half of the hay. What do we put this in which category? We put it in mild impairment. يعني a little bit, like مثلا they cannot see the letters in the sign that is hanged in the street. Not bad. طيب 6 over 18. هلا شوي it's increasing. The gap is higher and higher. So يعني 6 out of 12 is like half, يعني مثلا half. 6 out of 18 is like 1/3. طيب 1/3. This is basically moderate impairment. So basically, it's getting more, yani the patient is having more difficulty in looking at things that are really far. Once it reaches 6 out of 60, this is really bad. This is really, really bad. Yani very poor vision. Yani imagine someone is only able to see something 6 meters close to it, but a normal human being can see it from, this is the person trying to see the object, but this object is visible to a normal person من هذا. This is the normal. This is the abnormal. He has to be so close to see the thing. So 6 out of 60, severe impairment. Blindness is usually 3 out of 60. So if you cannot see the objects 3 meters, like from 3 meters, from the object, compared to a person that can see it from 60, you're blind. Okay? هلا legal blindness, okay? يعني for people who مثلا, they need to kind of get like an eligibility for like whatever cause, it's basically 20 out of 200. بس وقت. This is for this. Total blindness is basically they cannot see any lights. Like literally no light is detected. Nothing. هلا. Some people, they're kind of, okay, they don't know how to read the E. They're illiterate. Or if the denominator is more, it means the eyesight is bad. If the difference between the denominator and the nominator is really, really high, that's bad. يعني, if the nominator is low and the denominator is really high, it's really bad, yeah. But if the nominator is high and the denominator is really low, that means يعني amazing vision. If they're equal, خلاص. Yeah, it's ratio based. So basically, denominator is basically a normal people. يعني a normal person is supposed to see it from this number. كل ما كبر النمبر and the denominator decreased, that means, oh my God, like the gap is crazy. Okay? So as we said, some people are illiterate, they can't read, they can't count. So what we do? Oh, they're not even able to tell it, you know? So what do? We can put them fingers, ask them to like tell us how many fingers are there. We can try to do hand motion. This is specifically for command patients that cannot even like talk to us, you know? Like let's say they have a stroke or they have anything. So that's are the things that we could do. Then we can try to see light perception through the pupils and everything. If there was no light perception, they're totally blind. We have something called refractive error. Okay. Refractive error is basically errors due to whatever cause. Sometimes it's due to the spherical and something called spherical aberration. So the sphere itself has an issue. It's causing the rays are not converging into one point. So usually, مثلا, the converging lenses, they allow them everything to converge into one point. The lens has, I don't know, like something. It's either the shape is wrong. This can be not only in like glasses lenses, in our own lenses. So they can't converge at one point, and this is going to cause a blurred or unclear image. Mom? We have something called chromatic aberration. It has to do, chromatic means colors, so it has to do with the colors. So basically what happens is that the eye is not able to kind of understand the different wavelengths of different colors all at one time because they bend at different angles. So what happens is the color of the image is not going to be really clear. It's going to be blurry, and the color is going to be like not يعني هيك blurry, you know? This is what we call chromatic aberration. It's just chromatic has to do with the colors. So basically the wavelength, the different colors and the different wavelengths have like they bend at a different places. So that's why we kind of have the color unclear. Diffraction is, I think it's just basic physics يعني. They're straight, they go through a very long, like small area, so they bend and spread out. Well, this just reduces the sharpness of the image. So basically, if you see these things, it's going to be sharp, but if you see the others, it's not going to be as sharp. تمام؟ these things, refractive errors, they're basically كمان clinically significant. These are basically the hyperopia and the myopia. اللي هي hyperopia is farsightedness. So basically they cannot see the close objects. Why? Because you see the eyeball, it's really short. The image is converging outside the eyeball. عرفت علي؟ فلأنه it's converging outside يعني هي basically where does usually the image converge? It converges in the fovea. Why? Because we said the fovea has the most cones. فلأنه it has the most cones هناك the highest visual acuity will happen. So it's converging outside. حلو؟ This is what this is the cause of hyperopia. How do we correct it? We give them converging lenses, which is basically the convex. So we add plus. So we kind of increase and we add more distance for the eye so it can kind of, like converge into the right place. Myopia is the other way around. So basically the eyeball is too long and basically the lights are converging way farther than the fovea. And what happens is we give them diverging. So kind of like you see how like they don't directly converge. They kind of get dispersed and then they go into the lens and then they get diverted. Like converted together. Do you get what I mean? يعني هون we kind of want to decrease the distance where they we want them to directly خلاص converge away from the lens. هون we want them to diverge and then converge. Why? Because the eyeball is too long. Do you get the concept? Okay, perfect. So again, converging, we want them to converge at an earlier time because the eyeball is too short. In diverging, we want them to diverge a bit and then converge at the lens because the eyeball is too long. تمام? So hyperopia or farsightedness is fixed by converging or convex lenses, and usually by prescription it is a plus sign. Myopia is the opposite. Nearsightedness, eyeball is too long, so we fix it by diverging. We want to diverge them a little bit, and then they will converge at the lens, and this is basically concave or minus. And this is astigmatism. We mentioned it. You know, what happens is we have an irregularity or بالsurface or curvature of the cornea, فبصير في عنا multiple points مو بس one. فالvision is distorted. So that's why we put cylindrical lenses, and they help in kind of fixing the curvature and focusing the light all into the retina. Next, sorry. Okay, now let's talk. I think this is the last thing, accommodation. Yeah. What is accommodation? We talked about this. Accommodation is basically, it has to do with the lens. So accommodation is our ability to see something far away and close enough. So remember how we said, no, basically, our lens, okay, it has ciliary muscles attached to it. هدول ciliary muscles, they'll either make the lens fat or thin. Fat or thin. تمام؟ هلا when the object is far, okay, when the object is really far, okay, we don't really care if the lens is يعني basically the light has enough time to kind of converge. تمام? This is if an object is really far. So what will happen if the object is far? If the object is far, what will happen? The lens is going to be flat. تمام? And wait. So when we're talking about flat, what will happen? The ciliary muscles are gonna contract. طيب? They're gonna contract because it's really far وخلاص يعني we want the thing to pass normally through the lens. تمام؟ بس إذا نحنا we want if the object is near, we want the lens to become fat. So the ciliary muscles are going to relax. And this is how the lens is gonna change. So what happens is, the idea is, if we're bringing something that's far closer or something that's close farther, if it's far, the lens is gonna be thin. Because we don't need a lot of refractive power. That's the idea. And نحنا when we kind of make it fatter, we're increasing the refractive power. Do you get me? Near is fat, far is flat. Oh my god, it rhymes. Yeah. Near is fat and far is flat. True. Why is the farther flat? Because again, it has, you see, like in here, we have enough time for the lens to for the thing to go through it and then convert. But near point, it doesn't have a lot of time. So it has to go through like a really like dense thing, and like it has to have like a stronger refractive like power so it could like whoop refract. Is that clear? I like the mnemonic near as fat and far as flat. And for the lens to be fat, it has to be relaxed. The ciliary muscles have to relax. So if the object is near, the ciliary muscles are relaxed. If the object is far, the ciliary muscles are contracted to kind of pull the lens all together. تمام? I think it's easy صراحة. Accommodation is one of the easiest things ever. Now, this is something that basically accommodation rate is decreasing as age goes on. Why? Because the elasticity of the eye, of the tissues, everything in there is going to decrease. And because of that, we have something called presbyopia. presbyopsia is kind of presbyopia, sorry, or presbyopia. The idea is إنه basically this is kind of like far sightedness, but it happens due to old age. Do you get me? يعني it's basically hyperopia, but because of old age, that's why we call it presbyopia. Because like the etiology or the cause of the farsightedness is different than hyperopia. You get me? يعني presbyopia is just caused by old age. Basically, the lens is going to get a bit less elastic. It's gonna get the ciliary muscles are gonna get less elastic. Everything is just gonna like, but because of that, it's gonna cause the hyperopia. But hyperopia can be caused because of basically the eyeball like being too small and stuff. Is this clear? So how do we fix presbyopia? What kind of lens? concave ليش؟ It's basically okay. Okay, this is the last slide. Let's go up to okay. Basically, it's not gonna be concave, it's gonna be convex because we want to converge it. Why? لأنه you see the focal point is way برا. We want the focal point to be closer in here. So we want it to basically converge earlier. You get me? So it's gonna be a convex. Yeah, it's just like hyperopia. It's literally just hyperopia. يعني presbyopia is hyperopia, but it's just a different name because the etiology is different. Because it's caused by old age, and that's it. Anyways, thank you so much for attending. I really appreciate it. I hope I helped in some way. Inshallah ya Rab. I hope I made it easier. الله يوفقكم يا رب, and that's all. Please scan the code.
Thank you. I really appreciate it.
You're welcome.